Thank you, Tara. And hello, everybody. Good afternoon, good morning, depending on where you are. My name is Michael Fox. I'm joined today by Dr. Richard Shepler and Dr. Christopher Belanci, one of whom is in the room with me and one who won't be in the room with me. Dr. Belanci is, I assume, in Boston. Rick and I are together here in Cleveland. So the topic that we're going to tackle today is the intersection, the co-occurrence, the comorbidity of externalizing disorders, developmental complex trauma, traumatic situations, and psychoactive substances. And this is connected to SAMHSA's learning community relating to co-occurring disorders. And when we think about co-occurring disorders, we think about mental health and substance use co-occurring, but when working with adolescents, the comorbid inclusion of trauma, traumatic experiences, developmental trauma is so high that it's almost counterproductive not to include that as we go along. So that's what we're going to tackle today. This is, I think, the third in the series that we have done this direction. We've done, what have we done? Depressive disorders and something else. I should have written that down. But this is definitely the third. So we are going to go through a couple of the sections a little bit faster because they are a little bit repetitive if you have participated in the previous two. And my goal is to move through them pretty rapidly so that we can get towards the latter third of today's discussion, which really focuses on medications and medication usefulness and interactions with the three areas of intersections that we're talking about. And I think that will be really, really helpful to everybody. So I'm going to encourage everybody listening that if you have a question at any time, if you have a prompt at any time, please type it into the public chat area. We will try to get to it. One of us will always be talking, hopefully, or responding or listening, but the other two will be monitoring to see if there's questions, and we'll prompt each other to get to those, and we can have a discussion about that. And we encourage you to do that. So. Without further ado, I'm going to dive in here. So this is a repeat of the previous two, a little bit updated. But what we're talking about today is adolescence and all the different factors that influence and intersect with adolescence. And I know when I first moved into working with adolescents clinically, I thought that I had a grasp of understanding diagnoses and behavioral expression, but my learning was primarily based with adults. And adolescents are a very unique presentation and a very specialized period of development, and it takes experience working with adolescents to understand that. So keeping in mind where we are developmentally, extremely active period of brain development, growth of a large number of synapses. There's an increased sensitivity to dopamine, followed by a later pruning of connections towards more efficient organization. And if you're familiar in a passing way, kind of like I am, with neurotransmitters, you know that dopamine is heavily involved in the reinforcement pathway. And the reinforcement pathway is one of those areas that is undergoing very active development during this time of life as it's connecting itself to those higher brain regions in the frontal and prefrontal cortex area. And so that increased sensitivity to dopamine really means a lot when it comes to the influence of trauma and especially substances. The neuroplasticity of the brain, during all periods of life, but especially during this period of life when the development is so active, increases the foundational impacts of trauma and especially of complex trauma and also of substance use exposure. It also has meaning with any mental health issues that are going on because the youth is really growing into adulthood, experiencing whatever those mental health issues are for the first time during that period of life. When you think about mental health issues in adulthood, adults know about being adults, but adolescents are in the process of learning of moving into that period of life, and so everything is new, and they don't have the experience with it. So this neuroplasticity is very meaningful to all three areas that we're talking about today. So it represents challenges in terms of if there is no alteration of course, the foundations that are laid down during this period of brain development can be really impactful moving into adulthood in what could be negative or high-risk ways, but it also gives us an opportunity with those developing programs to work with teenagers and for those doing the direct clinical work with teenagers. It really gives a lot of hope that any little bit of change that we help that kid and that family make can have long-term, very positive consequences. And as a clinician, a lot of times we don't get to see that because it's further down the road. In terms of behaviors, what do you see out of a normal teenager? You should see, in all likelihood, degrees of impulsivity, some emotional reactivity, some risk-taking. This is all really normal teenage behaviors. These are underlined because these same behaviors are ones that are identified in the more risky realms that we're going to see associated with all three areas that we're talking about today, in the mental health area, really in the complex and developmental trauma area, and certainly and obviously with substance use. Impulsivity, the reactivity, and the risk-taking. So some degree of that is normal, but there is a threshold. And all of these areas overlap so strongly, and one thing really looks like another. So teenagers are moving into more complex social relationships. There's a higher degree of importance put on social comparison. If you have a teenager, if you've raised a teenager, if you work with teenagers, but especially at home in terms of family, it's easy to see and to think that friends are becoming more important than family with the teenager. I am happy to report that most research does not agree with that the family remains the most important. It's just that as the family, you don't always see that from the inside. So teenagers are less predictable. They're experimenting with things. They're supposed to be experimenting with things because they're practicing different ways of doing things as they move into adulthood and figuring out really what's going to work. And all of that relates to that neuroplasticity. They have all of these extra connections that eventually they're not going to use and that will get pruned away. But with those extra connections, they are encouraged to try different ways of doing things. So behaviorally, in terms of this period of development, I fall back to Erickson quite a bit in his developmental crises. And with teenagers, they're figuring out who they're going to be moving into adulthood. So as I mentioned, adolescence, this is coming from Jaworska and McQueen, and we've mentioned this before. But adolescence is a unique period relative both to childhood and adulthood. They are neither big kids nor little adults. They are teenagers, and it is a very particular period of life. So this is one of the ways that we conceptualize a lot of different aspects of what's going on in a youth in their life. With the center, with the big circle there being the kid, him or herself, some different aspects that we can consider that are going on developmentally. There's the physical maturation. They are coming towards the end of that. There's different spurts and bursts of that during adolescence, and then it starts to slow down as they move into transition age. But it doesn't slow down until transition age. The brain development, the same thing. Second most active period of brain development in our entire lives takes place during the teenage years. Second only to infancy. So it is a very, very active period of brain development. All of that going on, wrestling with sexual maturity and the social comparison and all the social aspects. So, and that's for every teenager. I mean, everybody goes through that. The teenagers that we are focusing on specifically today we're talking about kids who have the extra components of living with and growing into areas of mental health issues, experiences of trauma at various levels, and substance use, and the way those act independently from each other, and then also the ways that they interact. So, but no kid is an island. Sometimes they feel that way, but they're not. And there are different domains in the youth life that we like to consider when we are trying to help the kid understand, the family understand, to help ourselves understand the aspects of what's going on. There's the family domain, there's the friend or the peer domain. Most of them, in terms of the ones that we work with anyway, are still in school, or they are actively not in school, which is also an issue. But as we move into the older adolescents and even considering transition age, this could move into work or not work, so it could move out of school, but some sort of community that way. And then the last one is community itself, and that can include a lot of factors. For a lot of the youth that we work with in our programming, the community involves some sort of legal aspect, because when all those other areas are floating around, a lot of times there is some sort of legal involvement in contact. So, and it occurred to me as I was going through this the other day, written into this in an unwritten way, if that makes any sense, and I know that it doesn't. We should include a piece in here that acknowledges the cultural aspects that we should be considering for the youth as well. So, and that's not there in an overt way. So today, focusing on the intersections of mental health issues, and our drill down focus today is not just mental health issues, but mental health issues that have the stronger externalizing component. And for those of you that work with teenagers who are living with co-occurring issues, or that have legal involvement, or engaging in really risky behaviors, you see so many of these externalizing behaviors from the kids, sometimes from the family as well, high reactivity. So I think that this is going to feel very familiar to a lot of you, and the areas of overlap will also feel very familiar. In terms of mental health, half of all lifetime experiences of mental illness start by the age of 14. Very, very significant to us in that mental health issues are very, very common for teenagers. Half of all lifetime, that's not active, but all lifetime experiences of mental illness start by the time somebody is 14 years old. So this is, I don't know if we want to go so far as to say an expectation, but it's just not uncommon at all for teenagers to be living with and growing into mental health disorders. I think the rest of these numbers that we can skip, so that we can move on just a little bit quicker. I know that you will all look back on these slides later and study them, and then it'll be meaningful at that point. The conceptualization of the intersecting points that we're talking about with mental health, trauma, and substance use, I think it's important to remember that when a youth is living with all three of these areas, that they have many, many points of overlap, and they can overlap by two, they can overlap all three, but that it's also important to remember that these things exist independently as well. So there's a lot of points of overlap. Mental health overlaps with substance use overlaps with trauma, but trauma exists in that kid independently by itself, and substance use does, and mental health does. We can't tackle a single area at a time like we used to do in the old days. The old days being, I don't know, last week, but definitely 10, 20 years ago. We would tackle one area and then move on to the next. They need to be tackled in an integrated fashion. How do you do that? And that's what we're going to talk about today, so that we can focus on mental health issues, on substance use issues, and trauma issues, but we have to remain cognizant of the influence of all of the other areas and all of those overlaps as well. This is just one of the areas that we have used when we were focusing very specifically on co-occurring disorders. And we've been doing that for a long time, thinking about mental health existing independently, substance use existing independently, but then having mutual influence on each other and having very strong interacting relationships. So, and as we have moved forward in our conceptualization, we have realized through experience and research that trauma and complex trauma is interwoven into this so strongly that we have to include that as well. And so we move on to the multiple areas of intersect. And for those of you that work with teenagers directly, you see this so often that mental health concerns will predict that a kid is more likely, not guaranteed, but more likely to wind up experimenting with or moving into more than experimentation in the use of drugs or alcohol. There's about a 40% overlap with that if mental health concerns are identified in a teenager, about 40% of those teenagers are subsequently identified not to have a full-blown diagnosable disorder, but to have some substance use involved in their lives. The other side of that is it's a much stronger, a much bigger prediction that if substance use needs are identified in a teenager, there's over a 70% overlap of mental health issues being subsequently identified. So one predicts the other in the classical co-occurring consideration, but both mental health and substance use predict that trauma has occurred at some level or a traumatic experience. With substance use, we have certainly seen that trauma does not have to precede substance use in a teenager, but when a teenager moves into using drugs and or alcohol, the risky behaviors associated with that increase the chances that they're going to find themselves in high-risk situations that are going to wind up being, if not full-blown traumatic, victimizing at some level, secondarily traumatizing. So it doesn't have to come first, it can come second, and they predict each other. And both sides predict trauma, and trauma predicts both other sides. Taking a look at the mental health side of what we're going to talk about today in terms of externalizing disorders. In the introduction, before it gets into the specific areas and the specific chapters, but in the introduction of the DSM, they talk about what we in the clinical world have, well, the DSM is in the clinical world, right? But in the direct clinical world, have talked about in terms of externalizing and externalizing factors and behaviors for a long time. And we have considered teenage behavior a long time in terms of differentiating between externalizing and internalizing. And they talk about that in an introduction in the DSM. The externalizing group in the DSM includes disorders that can be expressed with antisocial behaviors, conduct disturbances, addictions, impulse control disorders. So as the DSM considers it, there's high similarities here. They're mostly grouped adjacently. Now the DSM does not directly include ADHD as an externalizing disorder. It's in the neurodevelopmental chapter in the very beginning. And we are probably, in our next discussion, going to tackle ADHD very specifically because it is so common. But we couldn't talk about externalizing disorders and not at least partially include a consideration of ADHD because it's so often the symptoms overlap the other areas that we're talking about in either an expressive way or in a real way. And so, what does that difference mean we're going to talk about here coming up? Coming from the National Comorbidity Study, if you're familiar with that, the Adolescent supplement, taking a look at the prevalence of comorbid disorders for people in the United States. Comorbid meaning there's more than one problem occurring in an individual at the same time, not the same thing as co-occurring. Co-occurring very specifically refers to the co-occurrence of a mental health disorder and a substance use disorder or issue occurring at the same time. comorbidity could be bigger. It could be a health issue and a mental health issue. It could be a mental health issue and a substance use issue. But coming from that study, taking a look at some of the expected prevalence in teenagers, they measured individually ODD, conduct disorder, alcohol and drug use, combined alcohol and drug use, and ADHD. They included that as an externalizing disorder. Overall, oppositional defiant disorder was measured as being the most prevalent of the externalizing disorders. And if you think about the description of, and we're going to get into it in just a second, the description of oppositional defiant disorder, it's teenagehood plus. So it's not unexpected that this will be the most prevalent at 13%. And they differentiated between, if we were using an adult model or the adult definitions, that kids would cross the threshold into diagnosability. But then when they used a more practical measure of saying, is this causing impairment in that child's life? So they had an overall number, but then they also had a severe impairment line, which I think was a little bit more realistic. Overall, ODD 13%, but with actual impairment, it was just over half of that at 7%. Drug and alcohol use was measured at 11%. They didn't differentiate between this is overall and this is impairing for teenagers. They just kept it as overall, which is understandable. ADHD, it's interesting that they were able to differentiate 9% of, this is 9% overall of teenagers have symptoms of ADHD that could be considered diagnosable, but when we use that line of severe impairment, it drops all the way down to 4%. I think it's interesting that they could differentiate between that. Conduct disorders, that seems really high, doesn't it? 7% of all teenagers, if we're not considering the line of severe impairment, could be considered to be living with and expressing conduct disorder. That's really high. It drops down to 2% with severe impairment. Looking at some of the areas, and we're going to take really quick looks at oppositional defiant disorder and conduct disorder, because those are the two that we encounter so commonly working with teenagers who have co-occurring mental health and substance use, and especially with histories of complex and developmental trauma. I'm not going to say guaranteed, but it's really close to guaranteed. At some point in their life, they have been diagnosed with ODD or conduct disorder. And this is just my take on it. It really depends on how much they have ticked somebody off clinically if they get a diagnosis of ODD or conduct disorder. So areas in the DSM, there's ODD, intermittent explosive, conduct disorder, antisocial personality, which is not actually in that chapter, but they include it as falling under that heading. Pyromania, kleptomania, and then other and unspecified. So we are going to touch on diagnostically the ODD and the conduct disorder, and then very, very quickly ADHD, just so that we have a conceptualization of it. So oppositional defiant disorder, and if you work with teenagers, I'm sure that you have, you've taken a look at this. Arranged by 3 categories, diagnosis has to meet at least 4 of these from any combination. So there's the angry irritable, there's the argumentative or defiant, and then there's the vindictive. So often loses temper, touchy, easily annoyed, often angry or resentful. Anybody have a teenager at home? Often argues with authority, often actively defies or refuses to comply, deliberately annoys, often blames others, and then the vindictive is self-descriptive with vindictiveness. So these are the diagnostic criteria for oppositional defiant disorder, any 4 of those. So I think that this really points out the importance of having experience and understanding the developmental period of adolescence. Because if you don't, it would be easy to overdiagnose somebody with oppositional defiant disorder. And as we get into our discussion about substance use and very, very most especially in terms of developmental trauma, this looks like developmental trauma. This looks like a description of developmental trauma in terms of behavioral expression. So developmentally, first symptoms typically appear early and rarely first appear after adolescence. ODD typically precedes the onset of conduct disorder, but it is not, and when I first started working with teenagers, I viewed oppositional defiant disorder as a precursor to conduct disorder. It's not, and the DSM points that out, that if a kid is going to move into developing, expressing full-blown actual conduct disorder, chances are they started out as oppositionally defiant. But oppositional defiance is a guarantee that anybody is going to move into conduct disorder. So, oppositional defiant disorder increases risks for later internalizing disorders, which is very telling. Antisocial behaviors make sense. Substance use, impulse control problems. It really predicts the later onset of substance use. Differential diagnostic considerations with ODD, ADHD. It has so many similarities, and then also but different, right? It's the same, but it's different. So etiologically speaking, it is different, and the presentation can be different. But the thing is when we talk about ADHD, and I think we mentioned this when we touch on ADHD, a kid can be living with attention deficit hyperactivity disorder, and they can be reinforced into doing oppositionally defiant expressive stuff through the frustration that ADHD can bring about in those around them. So, also differentially, DMDD, very, very similar expressions here. This is one area where the disruptive mood dysregulation disorder does not allow a comorbid ODD diagnosis. DMDD trumps ODD. And then conduct disorder and intermittent explosive disorder can have some similar appearances to ODD. Now, this is, for me, this is especially interesting when we start talking about developmental trauma, the risk factors here. Look at the risk factors. Temperamentally, harsh or inconsistent neglectful child rearing. Biomarkers include reduced basal cortisol reactivity. That's really interesting when we think about developmental trauma. The high comorbidity with ADHD, how do we differentiate? The difficulty is mostly confined to the hyperactive and impulsivity side. That is if a youth is experiencing ADHD inattentive type, they're not going to come to somebody's attention on the ODD side. It's mostly on the hyperactive impulsive side where it really looks like that and where the real differentiation needs to be made. So, and this differentiation then is further complicated as some may develop defiant behaviors. This is what I was talking about before, where a kid living with ADHD can be unintentionally reinforced and guided into expressing ODD-like stuff out of the frustration that everybody is feeling with their inability to sit still and pay attention. So, etiologically speaking, there's very similar neurological pathways in terms of the developmental trauma, of ADHD, and the cortisol reactivity. It's all wired in very similar and overlapping ways. So the understanding of the symptoms really takes a lot of attention. Moving into the I guess like I considered the bigger one, the conduct disorder. A repetitive pattern in which basic rights of others or rules are violated, at least 3 criteria in the last 12 months, and 1 has to be present in the last 6 months. So bullying or threatening, often initiating fights, has used a weapon, been physically cruel to people or animals, stolen while confronting the victim, forced somebody into sex, deliberate fire setting, deliberate property destruction, has broken into a house, lies to obtain goods, stolen without confronting. Out late at night despite parental rules, and that one's an important consideration, that if families don't care, that one doesn't count. Run away at least 2 times or 1 time in the very long term, and they are often truant. So the overall conceptualization of conduct disorder very often is what? It's like a pre-antisocial kind of thing, in that the person lacks empathy. For a lot of the youth that we work with, it's not necessarily that they lack empathy. It's that the kid is surviving. So, where is the consideration between this is how they've learned to survive, and this is crossing the line into an antisocial threat to the community? It's a pretty difficult line. Developmentally, with conduct disorder, the onset is most common between middle childhood and middle adolescence. Earlier is possible, later is possible, but onset after 16 is very rare. Earlier onset has poorer outcomes, and that's true with everything, isn't it? The earlier the onset, the poorer the outcome, the higher the risk. It's definitely true with substance use. And earlier onset can predict increased risks toward criminal behaviors and substance use moving into adulthood, persisting into adulthood, well into adulthood. I already mentioned that ODD is a common precursor. There's some suggestions that this may be more true in males. There's cautions about that. Then it's more recognized in males. I don't know if that's a failing of us clinically, or it's just gender stereotypes and expectations. But it's more recognized in males. Risk considerations, difficult temperament from the get-go, an under-controlled infant. I'm not really sure what under-controlled infant means. Typically, we do see a lower IQ, especially early on, and especially regarding verbal IQ. And there is a really interesting overlap here with developmental trauma, because with early neglect and high levels of measured cortisol, there is a later acquisition of verbal skills and lower IQ verbal scores. So there's a huge overlap with that. Environmentally, rejected, neglectful, inconsistent child rearing, harsh discipline, physical, sexual abuse, early institutional living, frequent caregiver changes, criminal substance use families. So, is this a recipe for creating conduct disorder? Is it kids are not necessarily born to become conduct disorder, but through developmentally traumatic experiences that they can lead into this? So, just the overlap is etiologically it's very difficult to explain and to differentiate. So, but the good news is on the other side, the approaches for helping the youth and the family find strategies to move through this would be the same. So, genetically, strong genetic component speaks to the importance of doing your genograms.
Mike, I'm looking at this and I'm thinking that, when we look at the risk factors related to externalizing disorders in general, that they also include things related to attachment and bonding with school, relationships with family members, but also parenting around supervision and monitoring and those things. And what to me is very interesting is that many of the evidence-based practices like multisystemic therapy, functional family therapy, etc., utilize the risk factors identified in the research literature to build their models. And so they looked at each of these individual components and they said, well, what do we need to do around the supervision and monitoring? How do we develop interventions around that? What about connection with school? What do we need to do around interventions with that? So when we look at these risk factors, you can also translate this into what does good practice look like? How do we address these issues that present in terms of a risk factor, and how does that translate into a clinical intervention?
Yeah, thank you. And with that discussion, I had a moment to look at the public chat box, and none of you have publicly chatted any questions or comments. Criticisms, hold off. But Otherwise, I want everybody to look up from their email and think about, if you have any questions, please include them so that we can get to them. It is hopefully more helpful to everybody. If you have a question, I'll bet you more than one person does. And I know from my part, I can't answer for Rick or Christopher, but once I start yakking, I just kind of fall into it, and I don't think about pausing for questions. So if you've got them, please add them. And then the consideration for ADHD. And this is it for ADHD, because I think we're going to tackle it more comprehensively later. But, there's the two sides, three possibilities. There's the inattentive side, then there's a hyperactive impulsive side, and then you can have a combined presentation. I know for myself, clinically, I was very guilty of missing predominantly inattentive only side. Because they don't come to your attention so easily. The hyperactive impulsive side does. If they're in your office for 5 minutes, you have a really good sense of that. But the inattentive side is, for me, it was easy to miss. 6 criteria from a list of 9 for the inattentive side. Same thing for the hyperactive side. So, you have to hit 6 of 9 on inattentive and 6 of 9 on the hyperactive side to get the combined presentation. So I'm gonna move through this this very colorful slide, and if you have it minimized, you've got to pull it up to take a look at this slide, which looks a little bit goofy. But in my head, when I created it made a lot more sense. It's supposed to be the areas that are all intertwining together. I'm going to move through this. And the developmental trauma piece, I'm going to skip the substance abuse piece today, guys, because we have talked about that pretty extensively in our last 2. And if you've got questions about that, we'll definitely tackle those at the end. But I want to make sure that we have time to get into our pharmacological consideration piece, because that, I think, is really going to target a lot of areas that listeners would have today. So the intertwined areas, ADHD, conduct disorder, oppositional defiant disorder are all comorbid at very high rates in children and adolescents. That is if you have ADHD, there's a really high chance that at some point, I'm not saying that this is entirely accurate, but at some point you've been diagnosed with at least ODD, if not conduct disorder. Early onset of these externalizing disorders really predicts that a kid is going to move towards using substances at some level. Social deprivation during infancy, high parent and child conflict. I mean, that just predicts everything, right? I mean, it's like the risk factors for a lot of these externalizing disorders kind of looks like an ACEs score assessment leading into this. So, the overlap here is really, really high. So, moving into our consideration of trauma and complex trauma, I'm going to skip the long dialogue descriptions there, just differentiating between a singular traumatic event moving into the classic PTSD and then the more complex trauma kind of stuff. But in our considerations, thinking about trauma, a traumatic experience, complex developmental trauma, can also consider victimization, abuse, neglect, all of these areas that are having an impact on the course of development, moving quite possibly, actually we could talk about prenatally and an epigenetic influence, but definitely from the earliest of infancy on through the teenagers that we are working with. We've done this slide in the past, so I'll move over this one pretty quickly to a consideration of complex trauma. Quite a bit of this is coming from the NCTSN. If you are not very familiar with the National Child Traumatic Stress Network, I encourage you to become very familiar with it. The descriptions and resources they have are fantastic. They just released 2 publications yesterday dealing with trauma in adolescents. I haven't read them yet, but they release things very regularly. I encourage you to get on their mailing list. So the take-home message from this is that kids and teenagers do not necessarily look like the expectation of trauma that we would have diagnostically coming from the DSM in adulthood. That is you're not going to necessarily see the same symptom presentation of the avoidance, the recurring dreams, those sorts of things, the reoccurring experiences. And it's especially true if it's complex developmental trauma. It's not a singular event that they're reliving. They're living it right now. And so their presentation can be very, very different than that we've come to expect from a set list of diagnostic criteria. So it triggers, for me, the differentiation between what's a survival skill and, so if a young person gets into a fight at school because they were, words were exchanged, etc., and because of high reactivity, you jump into the fight response. What's trauma versus what's conduct disorder? If that results into, a physical assault. So I think that it really becomes difficult to begin to dissect and differentiate. And so that's why we really encourage you guys to be thinking complexly about every kid that we serve and help, because there could be a multitude of variables that play into the behavior itself. Yeah, thank you. And that complex consideration, it's difficult to do. And that one slide that we had with the big bubble for the kid, and then all the little bubbles inside that that make up what the youth is, and then the different domains. We use a lot of versions of that, and if we have time, we'll end with an example of a functional analysis at the very end that is intended to help clinicians, and you can use it with families. It's not a secret clinical thing. Use it with families, use it with kids, use it with people around the youth to help them understand these very complex factors that are all overlapping and interrelated. So, Rick has mentioned attachment and relationships both at home and then also to the community and the school. With complex developmental trauma, and this is coming from the NCTSN, difficulty developing close relationships, extending into difficulties with peers and dating. In this part, when we think about what's going on developmentally and what that, if we fall back on Erickson, what that task is, it's connecting with peers and figuring out how you are going to be a social creature moving into adulthood. Some of this stuff really becomes pronounced during the teenage years. And, when we think about how trauma is expressed differently in teenagers, the really illogical thing from an adult perspective is a lot of our teenagers, rather than running away from the sources of trauma, they go running towards the sources of trauma. It's because it's what they've lived with, it's what they know. And when you work with teenagers living in those situations, when they get themselves into family situations where they are supported and they are cared for, where do you really see them act and lash out? It's when they have those periods of safety, and it's completely illogical from an adult perspective. But when we see how teenagers live with, survive with those developmentally traumatic experiences, it comes out in ways that are just sometimes incomprehensible. Trouble controlling and expressing emotions, and teenagers already wrestle with that enough as it is. It's what they're practicing. But when the brain development has been so impacted by complex and developmental trauma, and probably not just a single generation, but generations plural of difficulty controlling and expressing emotions, it's the only thing that the youth knows, and it looks like a lot of other things. Problems with authority figures, brain, body kind of stuff, any amount of stress can trigger that extreme reaction. That is they are either turned on all the way or they are not. And those are really the only two options. That's the highly reactive kind of stuff. Some kids may just shut down completely, and if they're not able to do that on their own, then you do get into the overlap of the substance use. And we see a lot of that with the dextromethorphan and things that really help people move into that disembodied experience. And dextromethorphan does a really effective job of that. That would be the Coricidin tablets or the Robitussin, things like that, the cough medicines. They really do help people just kind of float through the day, and so they can shut down chemically that way. Chronic physical complaints, that's true both with the internalizing and the externalizing disorders, and it has a high overlap with complex trauma as well. And increased and risky behaviors like smoking, drug and alcohol use, really high-risk sexual behaviors, partners who are way too old, and some body dysregulation stuff. Yeah.
So, I'm looking at this, and I'm also thinking about between trauma and externalizing behaviors. I think about masking, and what I mean by that is our kids may act out behaviorally, for example, at school, and we don't see the underlying trauma, we see the acting out behavior. The consequence might be suspension or put in an alternative school. So how well do we get underneath what the presentation is so we can help define it and design interventions? One of the things that we've seen with externalizing disorders is that we often miss the underlying learning disability. And so not only are we talking about trauma, we could be talking about, developmental and learning disabilities that get missed. And so oftentimes our kids have, multiple system involvement, and school is one of them. And if the learning, you could be looking at a sequence of interactions and events so that it begins with a learning disability, could be tied to the ADHD, where they're not learning the material and they're having difficulty, so they shut down. It could turn into a behavior where they get suspended. It could turn into hanging with negative peers, where they do other behaviors, and because the school gets aggravated or they're frustrated with what's happening, the child might be placed in another setting altogether. But we didn't get underneath it, and we missed it, and all we saw was the acting out behavior. And that's why it's so important with externalizing disordered kids to think more than just externalizing disorder in and of itself.
Yeah, it's really easy just to focus on those externalizing behaviors and then come up with a great behavioral plan, that's going to address that. But if you don't get to that underlying area, things are not going to change. And as a matter of fact, that really great sounding clinical behavioral plan may act counterproductively. So if any of you have any strategies when you are considering that high level of overlap and trying to understand etiologically and then helping the systems around that kid, first and foremost, most importantly, the family, but also if you're working with the school, if you're working with the community, with probation, helping them understand, we'd be really interested to hear your comments on that. And you can type them in that box. More symptoms from complex trauma that overlap so strongly with all the other areas that we're talking about. Difficulty expressing and identifying emotions at all. Teenagers are already wrestling with that. This just makes it all that much harder. Internalizing, externalizing stress, quick to anger, quite reactive. Lacking the skills to calm down once triggered, and boy, is that a big one. Always on the defensive. They can seem like they are tuned out, and they can seem like it's very, very intentional, and it is not. Some of the real developmental trauma experts that we work with talk about so much of this stuff occurring at a pre-conscious level. That is that the kid doesn't even think about what's happening until it is already in the process of happening. It's not a planful behavior, and helping people understand that as well. So. Easily overwhelmed, feeling detached, losing memories. That can look like a lot of different things. Lacking an ability to pay attention, tuning out. What does that look like? ADHD. So behaviors. A lot of this stuff we have touched on, and I'm kind of speeding through this because I do want to get to this last section here. this is on substance use, and we're going to skip substance use completely, but I do want you to appreciate how nice these slides look as we skip through them here pretty quickly. Actually, I think I might have skipped too far. Well, no, it's okay. We are going to consider areas of pharmacology here. That was the last piece on substance use. So this is encouraging us to take a look at the symptoms that we have identified, talking about these different areas and speeding through some, but really thinking about the developmental trauma and the mental health, the externalizing kind of stuff. If you take a look at the symptoms there on the right, can you place those in one of the circles by itself? Is one of those just with trauma, or just with substance use, or just an aspect of an externalizing disorder? I think that they can probably go in any of those, and they can go in the overlap very, very easily. And exactly what Rick is talking about, that we do need to get under a lot of these areas. And Julia, I see you typed something. Thank you very much. Your prize is not in the mail, but you are appreciated. So one of the greatest challenges I've experienced in working with youth who have complex trauma is that their caregivers do not see the root cause of the behaviors. Absolutely. Just focus on the actions themselves. And it's most importantly in the family, isn't it? When we're talking about helping them understand what's going on. Additionally, some of the parents also experience trauma, expect the youth to move on and deal with it like they had to. Exactly. Not seeing the connections there. Julia, I was on the phone with a program this morning with a case presentation, and it was about a young lady who was living exactly what you're talking about, in that both parents had lived with a significant amount of trauma themselves. Both parents were extremely reactive. As a matter of fact, this one had included a call to Child Protective Services because of the high reactivity. But the parents really blaming the kid for the reactivity and not adapting to what she had lived through herself in the way that they had. And then the challenges of working to help the youth reconcile what's going on, but then also working with the parents and increasing their recognition of what's going on. So you have to help increase the motivation for the kid towards change, but then just as, or even more importantly, you have to work with the parents and the caregivers in first increasing their motivation to recognizing what is going on before you can even move to the point of helping to coach them towards the skills of the things that are going to be helpful. So, and that is an enormous challenge.
One of the my comments to that, Mike, is the therapies that seem to work best actually are family-oriented contextual therapies where you're working with both the individual and the family unit because of systemic trauma and mental illness and substance use. So if the child's to get better, we not only have to work with the child, we have to work with the family as well.
Yep, and I'm glad you pointed that out. I just had the expectation that was being done. That's a silly expectation, isn't it? Yeah. So moving into our considerations about pharmacotherapy, if you are not familiar with the work of Bessel van der Kolk, I encourage you to take a look at one of the big leaders in the consideration of developmental trauma. A quote, I think that this is from his most recent book, 500,000 children in the United States currently take antipsychotic drugs. Children from low-income families are 4 times as likely as privately insured children to receive antipsychotic medicines. These medications are often used to make abused and neglected children more tractable. These medications make children more manageable and less aggressive, but they also interfere with motivation, play, normal developmental kind of stuff. So we're going to move into a consideration now of using, and I'm going to skip ahead of this really pretty slide, to a consideration, and I think Dr. Balanci is going to take over at this point because you have the great benefit of having Dr. Balanci able to talk about the influence and the considerations of pharmacotherapy for kids living through what we are talking about. And again, I encourage questions that we will we'll make sure that get to Dr. Balanci as he is going through his discussion.
Thank you, Rick and Mike. I just want to emphasize the conversation around developmental and complex trauma disorder. You know, part of the challenge is that, as you've heard in this description of the disorder, it's very broad, and that was one of the reasons, as I understand it, that it was not included in the most recent diagnostic manual. There was almost a concern that it was so broad it encompassed almost all of the child psychiatric disorders, and that's in a sense true, as described by Mike talking about the ways in which externalizing disorders can be manifest as a result of an underlying trauma condition. And the reason this is really important is because in order for us to assign the right treatment intervention, we have to have that right formulation of what is driving the behavior. And if you're not asking about trauma, you're not going to solicit the appropriate understanding of how trauma may be informing and influencing the behavior that the adolescent is presenting with, the risk-taking behavior and the other externalizing elements. And that's going to cause you to then go down a pathway that may not be the right interventions for the situation. And what we see with the use of psychotropic medications, and particularly antipsychotic medications, as Dr. Vanderkolk has pointed out, is that these medications are in large part being used to control the aggression that results from either the underlying trauma or other behavioral drivers for that behavior. And you know, the interesting thing about particularly the second generation antipsychotics, so these are medications like risperidone, quetiapine or Seroquel, aripiprazole or Abilify, is that they do seem to almost in a diagnostically non-specific way adjust the threshold upon which these young people get triggered. And so it can decrease the frequency and the intensity of these rageful episodes, these aggressive episodes, these property damaging episodes. And that is not necessarily a confirmation, for instance, that the child has a bipolar disorder. It really is medication, just like the stimulants work for ADHD. They also work for children who don't have ADHD in terms of increasing their attention, which is why we see such a significant diversion for some of the stimulants in college-age youth who are taking the stimulants to cram for exams or to increase their focus in order to get their academic work done, as well as just looking to get high. So, you know, the increase in the use of these antipsychotic medications has been very significant. And I'm just going to run through some of the data. So the overall reporting rates of all psychotropic medication for young people between the ages of 6 and 17 years old is about 7.5%. And you'll see a much higher proportion of males to females in medication use. And this is probably being driven by these externalizing disorders. They're hard to miss. They demand a lot of attention, and people want to get in there and treat it because it can be so disruptive to the individual and those around them. Females in general tend to be a little bit more internalizing in their manifestation of their mental health challenges, and so you look at more depression and anxiety. And that's a little harder to access and to see, and so that might be the reason why girls are on less medication than boys. And then you see a racial bias around non-Hispanic white versus non-Hispanic Black, and then Hispanic at the lowest percent of utilization. Some of that may have access issues. This was data reported in 2014 that was looking even earlier than that. So the Affordable Care Act and universal access to insurance, which is still not universal in all states, is just coming online around this time. So it'd be interesting to look again, particularly at states that had Medicaid expansion, whether or not we're seeing a leveling off of the medication utilization. But then, as Mike pointed out, quoting from Bessel-van-der-Kolk, we see much higher rates of antipsychotic use and medication use in publicly insured or Medicaid-insured youth, almost 10%, compared to privately insured of 6.7%. And if you add in foster care youth, you'll see an even higher rate. Some estimates of around the mid-30s, so 32 to 35% of foster youth are on a psychotropic medication. And again, I think the externalizing disorders are the big drivers of that medication use. So between 1993 and 2009, we saw antipsychotic prescriptions for children 13 years of age and younger growing more than 7-fold, and it quadrupled among adolescents between the ages of 14 and 20. And what was really striking about this particular study is that not all the visits with antipsychotic medications even had a mental disorder diagnosis listed on the billing form. Antipsychotic medications are the fastest growing class of psychiatric medications. And again, looking at a Medicaid population between the ages of 3 and 18, it grew 62% in just a 5-year period between 2002 and 2007, with ADHD being the most common diagnosis in half of the young people who were prescribed antipsychotic medications. And we're concerned because these medications carry a much higher potential risk of side effects, including diabetes type 2, where we noted a 50% increased risk for children being prescribed antipsychotics. This was actually from the New York Times when Steve Crystal and his group at Rutgers University was reporting on the increased use of antipsychotic and the discrepancy that you see on the left-hand side of the slide between privately insured and Medicaid-insured youth. And SGA stands for second generation antipsychotic. Between 2004 and 2008, for the 6 to 18-year age group, we saw a 22% overall increase in the use of a second generation antipsychotic and a second medication. So now we're talking about polypharmacy, the use of more than one medication at a time. And the most significant increases in this study were starting to occur not in youth that had been hospitalized or were in foster care or on disability or had an intellectual disability, which are some of the Food and Drug Administration approved indications for the use of antipsychotic medication. We started seeing this use broad and even into more general outpatient settings. And this is just to remind us that, it's pretty rare when you would justify using a psychotropic medication without a corresponding therapy. And this came from a Center for Healthcare Studies Faces of Medicaid report by Sheila Pyries and Catherine Grimes, looking at the linkage between a billing form, so most of this is Medicaid claims data, for a psychotropic medication, and then looking to see whether or not there was a corresponding bill for a therapeutic intervention. And in almost half the cases, they were unable to confirm that the child who was being prescribed a psychotropic medication was actually in therapy. And so what we're starting to see now in the practice is a growing use of psychotropic medication in the absence of a therapeutic intervention, which is really hard to justify. And then again, when we look at foster youth, we see psychotropic prevalence from 14 to 30% in community settings. And then if you look at therapeutic foster care or group homes or residential treatment settings, we see much higher utilization. And once you're on one medication, it's very common that you'll be prescribed more than one medication.
Hey, Christopher, just to interject for just 1 second. 2 slides ago, you mentioned about the overlap with prescriptions and behavioral health care, but Don Howard has typed in, and I don't know if you can answer this directly or not, the rate of kids receiving counseling services and medication versus just medication, and is there any known measure of, is this is a psychiatrist prescribing, or is this the PCP? Without the training prescribing. And I think you already tackled the counseling service one, but don't know if you know anything about the latter part of that or not.
Yeah, this is the slide that addresses the first part of Don's question, and this is not unique, this particular study, in finding that there are many young people who are being prescribed medication in lieu of therapy. And again, in the absence of perhaps very stable ADHD on a stimulant, where there's already been some parent management training, there may not be a requirement for ongoing therapy. Although those young people often will have comorbid conditions, including substance use disorder conditions or underlying trauma, that would benefit from a therapeutic intervention that might then allow the young person to be off medication later in life once those symptoms and behavioral disorders are under better control. In terms of the second part of the question, that's much harder to get at, particularly when you're looking at Medicaid claims, because they don't identify the specialty of the prescriber. So we don't really know the answer to who's doing or who are the big prescribing drivers. And you also have advanced practice nurses, you have certainly primary care docs, in some states and localities you have psychologists who are prescribing. But I would say that when we look at the complex medication regimens, when we're able to pull that cohort out, so young people who are on 3 or more psychotropic medication, those are typically child psychiatrists that are doing that more complex regimen, or advanced practice nurses. Most primary care docs would stop after 1 or 2 tries. Now, in some rural areas, they may not have that option, in which case psychiatric consultation programs can be very effective in supporting the prescriber, who may be a primary care doc, a family practice doc, in a rural location or a medically underserved region of the country. They can have access to child psychiatric consultation to help support their prescribing. There's some estimates that as many as 50% of primary care visits have some kind of behavioral health component, whether that's articulated at the outset of the appointment or not. But primary care docs are really the front line of managing behavioral health disorders, and so coming up with ways to support their knowledge and their prescribing practice is going to be really important for us.
Thank you, and thanks to Don as well.
Yes. So this slide just reminds us again about the polypharmacy issue. So the first column, TANF, is the temporary assistance for needy families. So this is folks that have access to Medicaid secondary to poverty. And then the middle column is SSI and disability. And then the final column is foster care youth. And what you'll see is the foster care youth are being prescribed multiple medications, even in excess or at just about higher rates than the disabled population. And that was really striking to the folks that pulled this data together at the Faces of Medicaid study. Just because, even though you're in foster care, that should not necessarily equate to such significant disability as those who are eligible for SSI. And so in 4% of the cases, the young people who are prescribed psychotropic medication are actually taking 4 or more medications simultaneously. In 15% of the cases, they were on 3 or more, and in 30% of the cases, they were on 2 medications simultaneously. So we're seeing a high rate of polypharmacy as well as just a high rate of medication utilization in general. And what we also saw, if you look from state to state, is there's tremendous interstate variation in the use of these antipsychotic medications particularly. So from a low of just under 3% in Hawaii to almost 22% of youth between the ages of 3 and 18 were being prescribed an antipsychotic medication in the Texas foster care system. Now this data is back from 2007. Since that time, Texas has done a lot of work in addressing the concerning trends around psychotropic medication use for their foster care population, and that number's come down. And this slide really brings us back to kind of the unifying theme. And we do have a little time, but it'd be great if we had some questions or discussion. Otherwise, I am wondering if it would make sense for us to go back to some of the substance use slides and just bring that part of the triad back into the conversation. But I think thinking about the function of the behavior particularly when you're talking about externalizing behaviors, becomes really important, and not missing the prevalence of traumatic conditions for this population and how that intersects with substance use disorder. So in terms of kind of concrete messages to take home from today's discussion, one is having a high rate of index of suspicion and asking in developmentally appropriate and culturally competent ways how trauma may have been experienced by this young person. You know, in some communities, it's so endemic that parents wouldn't necessarily alert us to their child being traumatized because they may not recognize it in themselves, they may not recognize it in their community, they may not recognize it in their children, or they may have an underappreciation for how it impacts their behavior. And they may just be focused on the end product of the trauma, which is that externalizing behavior and taking a strictly behavioral approach, which is not always going to work for some of these young people who have had traumatic experiences or are still in violent communities where they're feeling unsafe. I think, you know, Mike's point about almost being drawn to the flame of the fire as a coping strategy is very common and consistent with my clinical experience as well, that these young people, you would think they would almost be running from the potential traumatic source, but sometimes they're actually drawn to it in an effort that the closer they're to it may help them to be able to manage the sequelae or whatever unanticipated reactions may come from the other people in their environment who are behaving in ways that would theoretically scare them, but that they're still drawn to be near.
Yeah, thank you. Very, very helpful. And again, and we can definitely go back and take a look at the substance use pieces and some of the overlap there. But I would again encourage you, I know I've been beating this drum, if you have any questions, you have a highly qualified, long experienced, home-based psychologist and extremely qualified child psychiatrist online, and now is the time to get any questions answered that you would have concerning working with the behavioral overlap, you know, thinking about the pharmacological influence of the behavioral overlap, of working with kids who are in these really, really interwovenly complex situations. And if you're working with teenagers with areas of risk, you're working with these youth. This is not a rare situation for these areas of overlap in the high risk situations. So if you've got them, bring them on. So
I'm going to make a comment in between, and then I have a question for Christopher. You know, one of the things that again, I want to bring it back to home and school, but particularly school, that we have this kind of dynamic where we've got a lot of alternative schools, and you know, many of them are very good. But what we do is, instead of trying to figure out how to problem solve and keep the child in the public school where their friends are, we oftentimes don't problem solve as a system, if you will, and they are put somewhere else. And the reason I bring that up as a concern is that most public schools have the protective factors embedded in them. And what I mean by that is all the extracurriculars that are involved in a public school that may or may not be available in an alternative school. Those protective factors are what help kids with externalizing disorders get better. And so I don't want to start taking away those things that help make kids, you know, get better without having tried to problem solve ways to keep them there. So for example, it could be, you know, what are the strengths of that child, the talents, the abilities. It could be sports, arts, music, and think about that and how that's organized. With each of those, you have coach mentors you have highly structured environments, you have ways of keeping kids busy in positive ways, all things that you're trying to work on with kids with externalizing disorders. So you're trying to keep them from negative peers, unstructured time, all of that. So sometimes the solution is not diving into the problem, but diving into the protective factor. And where do those exist most in a kid's life? Well, they're naturally occurring at school. But they're naturally occurring in the public school in particular, less so, I believe, anyway, it's been my experience, in some of the alternative school settings. So that's just a comment I wanted to make. And my question to Dr. Belanci is related to, kids with externalizing disorders, have a high substance abuse disorder rate, prevalence. When does it, we've experienced some child psychiatrists that are a little risk aversive when it comes to prescribing for kids who are using substances, others that are more willing to do that. Are there certain situations that you would say, no, this is not a good indication for prescribing versus we should always think about psychopharmacology regardless, intervention regardless of whether they're using substances or not?
Yes, it's a great question. The first thing I need to know is, having a good formulation of what I'm treating. And I think this slide is a great one to kind of focus our attention on the interface between the mental health condition, whatever underlying trauma the young person may have experienced, and whether it goes to the full developmental trauma disorder or PTSD, and then substance use and what substances they're using and the frequency and what they get from using the substance, because, in some cases, I think the substance use can be an attempt to manage the feelings related to the trauma or the mental health symptoms. And I need to know as a prescriber what else they're taking so that I can understand how it's going to interface with anything that I prescribe. There are some prescribers who have a zero tolerance, meaning if a young person is using substances, they're going to insist that that young person cease using the substances in order to then receive a psychotropic medication. I think given the intersectionality that we're talking about this afternoon or this morning, depending on your location, I think that's a problem because some people aren't going to necessarily be able to give up their substance use if we're not providing them something in replace of that to address and treat the underlying symptoms related to their mental health condition. In terms of trauma and specific psychotropic medications, I think there's very little evidence that we have psychotropic medication that is helpful with the underlying symptoms of traumatic disorders or conditions. Sometimes I can use blood pressure medications that we use for kind of a hyperarousal state associated with traumatic conditions, and it can break the cascade that can be associated with anxiety states that can progress into full-blown panic disorder. And so that may play a role while you're simultaneously treating the traumatic disorder with a ideally behavioral evidence-based condition like trauma-focused cognitive behavioral therapy. Or similarly, the most common situation I've dealt with clinically around substance use is folks that have an underlying anxiety or depressive disorder. And certainly I'll do a lot of guidance around how those conditions manifest for the young person, and then talk about the potential harms associated with the substances they may be using. But it may mean I have to use, for instance, a selective serotonergic reuptake inhibitor, or SSRI, like Prozac or Zoloft or Celexa or Lexapro, to manage those symptoms while simultaneously engaging in motivational interviewing and other substance abuse interventions in order to help them to wean themselves off of whatever substances they're using. So, in my experience, it often has to be a both and not an either or.
And that was a question that I was going to ask you that you addressed there as part of answering what Rick brought up, which was a really good point and something we run into a lot in terms of prescribing to kids who are using and a willingness to do so. But exactly what you segued into there, Dr. Belanci, in terms of, is there something that'll help tackle the symptoms of externalizing disorders? And really we run into this a lot with high reactivity in kids, and that all or nothing, that 0 to 100 response immediately, that also helps to moderate or modulate some of the impact of developmental trauma. So, and from your answer, it sounds like there is no one single magic bullet that can help to do both of those things at the same time. Because you're thinking it's an and, not an either or kind of consideration, if I understood that correctly.
That's accurate. There was some evidence, a slight signal of an effect, but it wasn't statistically significant in some of Dr. Cohen's work at the National Child Traumatic Stress Network, that SSRIs could be helpful. She was particularly looking at Zoloft for PTSD in young people. But it was not a strong enough effect to be statistically significant. That said, I will sometimes use an SSRI for young people who have experienced trauma, but only usually if there's comorbid depression and anxiety, which there often is. And then taking a careful history to better understand any substance use that they're involved with, and try to partner with them about moving towards abstinence of their substance use, as I'm better able to manage their anxiety and traumatic symptoms, hyperarousal associated with the trauma, and then the other underlying mental health conditions. But it really, it's critical for us to understand what contributions we're getting from the so-called mental health domain as well as the trauma domain and the substance use domain. And I also think it's critically important to see whether or not whatever the traumatic drivers are for the behavior, whether or not they've abated, because it becomes problematic if I'm trying to treat symptoms in the context of ongoing trauma. And so that's really important as well. And then the role of Child Protective Services to ensure that we're addressing ongoing trauma, ideally preventing that from occurring, because it's almost unethical for me to try to manage to reduce the traumatic effects in the context of ongoing trauma.
We have one last question, and we'll call it for today. Julia asks, I manage a program that supports youth and their families after behavioral crisis, took them to the hospital, and my team intensively outreaches with them to engage them with long-term services. Do you have any suggestions on how we can help support our hospital partners in better understanding, recognizing these overlapping symptoms that you've covered?
That is a really common problem. Go ahead, Christopher.
Well, I wish I had an easy answer to it. It sounds like Julia's team is really informed about the intersectionality, but their hospital-based partners may not be seeing these young people through that same lens. I think sometimes there's an opportunity to do a debrief even with our partners. Sometimes we do debriefs with young people after they've had a behavioral episode, and we may involve their parents or school staff depending on where the behavioral episode happened. But I think it might be an opportunity to also debrief with our inpatient and emergency department staffs. Sometimes that takes an introduction at an administrative level, but if we see ourselves as allies in the care of these young people and their families, hopefully that would create an opportunity to have these kinds of conversations. I don't want to call them case consultations, but discussions about scenarios and specific young people who may have had positive outcomes, but may have also had negative outcomes as a result of our interventions at the service array. And I think that can be really helpful in informing and then partnering with folks at all levels of the mental health service system. so that we have a shared understanding of what's driving the behaviors that are calling the young people into attention and treatment. So that would be my approach, is to try to partner and collaborate in the care of these young people across the service array.
I mean, it might be a really good place to use, you know, a wraparound approach to bring the hospital into that, or bring the wraparound to the hospital.
Yes.
As well.
And there are some models of that, including in residential settings. There's some res-rap models that have been emerging. So Eric Bruns has been working with some folks on the West Coast, where the residential unit is the base for the behavior, but immediately upon entry into the residential, a wraparound team is assigned to try to minimize the duration of the residential stay, and also ensure that the interventions being used with the young person are adaptable and implementable in the community and home-based settings. And then that same RAP team would continue to provide aftercare for some period of time. And the new Family First Prevention Services Act, which is the child welfare financing reform bill that was passed just about 2 years ago, and is due to be implemented this fall, except if a child welfare system wants to delay for 2 years, which many jurisdictions are doing. But the Family First Prevention Services Act actually has a requirement that qualified residential treatment programs receiving federal funds, largely through the child welfare system, provide 6 months of aftercare. And so it's not.
Yeah, we might have lost Christopher. So it sounds like there's some good solutions to, I'm going to talk like Christopher might talk. It sounds like there are some solutions utilizing some of the new funding opportunities in wraparound to bring kids back into the community successfully. We would like, we're almost to our end here, and Tiara, if you wanted to give folks instructions on how to complete the survey.
Actually, Tara, before you have your piece, I want to mention real quickly, Julia, thank you very much for your questions. If you still have questions, and Julia, if you have more on that, we run into that quite a bit, not just with hospitals, but with all the entities that serve youth. You can contact any of the three of us. Our contact information is at the end, which I will click to here. And Tiara will tell you how to access this. But we will be happy to try to point you in the right direction for any additional questions that you have. Tiara will tell you how to complete the survey. We hope that you all do, because we will pay attention to that. And thank you all very much, and I hope you all have a good remainder of the week.
So I did post a link to take the survey right there in the public chat, and if you also stay connected, the survey link will also pop up for you. And Christopher is also back, so I will leave it to him to give us our closing remarks.
I would just thank everybody. I don't know at what point I got cut off, but hopefully you heard mostly of what I was saying about Family First and its 6-month requirement for aftercare.
We did. It was just at the very, very end.
Good. Thank you, and have a good afternoon.
Thank you very much, everybody.